a clinical vignette like this. 86 years old man in rehabilitation nursing center brought to emergency department. Reason why? Sudden onset of confusion and aggressive. Number one. Number two, competitive behavior. Okay, it's over past 12 hours. Past medical history with mild or chronic obstructive pulmonary disease, COPD, and mild dementia. Okay, have a four thing. Number one, sudden onset confusions and aggressive com- compactive behavior, and have a COPD and mild dementia. Also noticed skipped both breakfast and lunch today. Now physical examination, no fever, 37.1 Celsius, and RR 25 breaths per minute, heart rate 106, which is fast. Oxygen saturation, SpO2, 87%, so which is lower than 88%, and patient 86 years old. Okay. Pulmonary percussion reveals dullness. Auscultation demonstrates bronchial breath sound over the right lower lobe. Frontal chest X-ray confirms a new focal consolidation. Okay. So which of the following is the most appropriate root cause diagnosis? Community acquired pneumonia, GCAP, aspiration pneumonia, or rapidly progressive vascular dementia, or acute exacerbation of chronic obstructive pulmonary disease, or acute pulmonary embolism. So the correct answer is community acquired pneumonia, CAP, or aspiration pneumonia. Reason why? So detailed clinical explanation. This case classically illustrates a typical presentation of acute infection in elderly patients. But this one not fever, rather than presenting with classic symptoms such as what? Nope, 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 nope. Rather than presenting with the classic symptoms such as high fever, productive cough, pruritic chest pain, but in elderly patients frequently present with a hyperactive delirium or acute states of confusion, agitation as a primary sign of systemic or localized infection. Because the elderly patient frequently present with hyperactive delirium, acute state of confusion and agitation as a primary sign of systemic and localized infection. Even Even this a community acquired pneumonia, but the patient doesn't have a typical sign symptoms. But because the patient elderly, so that's why different. Patient presented with hyperactive delirium, acute state of confusion and agitation as a primary sign of systemic or localized infection. Atypical delirium as a warning sign. The patient's acute behavioral shift over 12 hours. Agitation, compactiveness on a baseline of mild dementia indicates delirium. Skipping meals reflects acute anorexia due to systemic stress. The absence of fever, perturbation this A February 37.1 Celsius is a common in patients over 85 years old due to age-related blunting of the hypothalamic thermoregulatory center. Oh wow, remember that. God is elderly, they're not easy to show fever. Physical and radiographic evidence. Physical examination confirms focal lunge consolidation, tachypnea 25 per minute, hypoxemia SpO2 87%, donors to percussion, and bronchial breath sounds indicating dense LS lung tissue transmitting airway sounds directly. Anatomic location consolidation in the right lower lobe on chest X-ray in the elderly patient with cognitive impairment strongly points toward aspiration pneumonia. Okay, in the X-ray, it saw consolidation of right lower lobe in elderly with the cognitive impairment strongly points toward aspiration pneumonia. As the right main stem bronchus is a wider, shorter, and more vertical because the right side shorter, more vertical. So keep in mind, for those reasons, so we diagnose the patient most likely have a community acquired pneumonia, CAP, community acquired pneumonia. So aspiration pneumonia. Why other option is not correct? Not correct. Acute exacerbation of COPD, AE COPD, characterized by diffuse bronchospasm with widespread wheezing and bronchi bilaterally. AE COPD does not produce a localized donors, bronchial breath sounds, or a new focal consolidation on chest imaging. Acute pulmonary embolism, that's not correct answer because causes the dyspnea, tachypnea, tachycardia, and hypoxemia. However, early chest radiographs in pulmonary embolism are typically clear or normal, or show non-specific signs like a Westermark sign of Hampton's hump, lacking focal consolidation, and true bronchial breath sounds. If a pulmonary embolism, so typically clear or normal in chest radiograph, X-ray, or show non-specific signs like a Western mark sign or Hampton's hump. Lacking focal consolidation, pulmonary embolism is lacking focal consolidation, and true bronchial breath sounds. And also, can pulmonary embolism for side symptoms suddenly cause dyspnea, tachypnea, tachycardia, and hypoxemia. Are the causes. Now, why rapidly progressive vascular dementia also wrong? It follows a stepwise decline secondary to discrete cerebrovascular events. While it causes cognitive deficits, it cannot explain acute respiratory distress, hypoxemia, or focal lobar consolidation on chest X-ray. Now, detailed disease treatment and management: pneumonia, aspiration pneumonia in the elderly. Number one, airway and oxygenation management, oxygen therapy, uh, titrate supplemental oxygen via nasal cannula or venturi mask to maintain SpO2 greater than 88. Yeah, to maintain. Oh, this a very old patient, over 80, 85, 86 years old, but they still maintain SpO2 greater than 92% or 88 to 92% if COPD hypercapnic dry is a concern. Airway clearance, chest physiotherapy, positioning, and frequent suctioning if secretion clearance is impaired. Number two, empiric antimicrobial therapy regimen for inpatient non-ICU healthcare facility residents. Empiric antimicrobial therapy regimen for inpatient non-ICU healthcare facility residents. Option 1, beta-lactam, such as ampicillin, surfactant, 1.5 gram to 3 gram IV, Q6 hour, so which is 4 times 6 hours, every 6 hours, so stand for 4 times, or ceftriaxone 1 gram to 2 gram IV daily, plus a macrolide, for example. So this I have to use antibiotics, plus a macrolide such as azithromycin 500 milligram IV or PO daily. That's option one. Option one use a beta-lactam plus macrolide. Beta-lactam we use ampicillin, sulbactam, or ceftriaxone. Okay, and macrolide we use azithromycin. Option 2, respiratory fluoroquinolone monotherapy, such as levofloxacin or moxifloxacin. That's the option 2. Option 2, we use only one drug. They call this fluoroquinolone monotherapy. For example, the use of central respiratory fluoroquinolone monotherapy, fluoxetine group like a levofloxacin 750 milligram IV or PO daily, or moxifloxacin 400 milligram IV or PO daily. Now, anaerobic coverage for aspiration. So, if lung abscess, emphysema, or severe periodontal disease is suspected, so then we need to add metronidazole. If my lung have an abscess or pus or periodontal disease severely, then we add metronidazole 500 milligram PO IV, so every 8 hours, or clindamycin, or utilize ampicillin, sulbactam, piperacillin, tazobactam. Okay. Now, if my lung have an abscess or severe periodontal disease, now we add the, because this is anaerobic coverage, so we add metronidazole or clindamycin or utila ampicillin sulbactam, piperacillin tazobactam. Duration typically 7 days, provided the patient is afebrile, which is no fever for 48 hours and clinically stable. Next, supportive care and delirium management. Isotonic IV hydration, correct dehydration cautiously, monitoring fluid balance to avoid exacerbating underlying heart or kidney conditions. Non-pharmacological delirium protocol, reorientation, frequent family presence, room illumination during daytime, minimizing nighttime sleep disruptions, and avoiding physical restraints. Pharmacological delirium management. Avoid benzodiazepines. If agitation poses severe safety risks, low-dose atypical antipsychotics, for example, quetiapine or haloperidol, may be used short-term at minimal doses. Pharmacological delirium management. Avoid benzodiazepines. If agitation poses severe safety risk, low-dose atypical antipsychotics. Quetiapine, haloperidol may be used short-term at minimal doses. Next, aspiration prevention protocols. Speech language pathologist, SLP evaluation formal bedside swallowing study to assess gauge reflex and dysphagia, dietary and positioning modifications, thickened liquids, mechanical soft diet, upright positioning 45-90 degree during and for 30 minutes after meals, chin tuck maneuver. Use a chin tuck maneuver, huh? So thickened liquid, mechanical soft diet, upright positioning 45 to 90 degree during and for 30 minutes after meals to prevent about stuck something in the airway. Huh? They call this a chin tuck maneuver. Okay. So anyway, in summary, in this condition, the patient number one, this is a old age elderly patient. So the patient have a side symptoms what? Not really fever, huh? Not really some kind like a young patient. But in contrast, older patient, they just show the side symptoms like agitation, delirium, something like that. You know, also the patient did not show this fever, whatever. Okay, jet high, heart rate highs, and SpO2 drop, 87%. Okay, so in this condition, so most likely diagnosis this acute community acquired pneumonia or aspiration pneumonia in elderly patient. Okay. Now and then treatment detail and treatments management of this condition. Number one, airway and oxygenation management. Number two, empiric antimicrobial therapy. Number three, supportive care and delirium management. Number four, aspiration prevention protocols. Number one, airway and oxygenation. This is important, huh? So need to maintain the SpO2 greater or equal 92% or 88 to 92% or higher. If the patient have a COPD, hypercapnic drive is a concern. Also, airway clearance, make sure. So, physiotherapy, positioning, frequency suctioning, important. Make sure secretion clearance. Okay. Number two, which is antibiotic. So, option A, which is beta-lactam or ceftriaxone. If a patient have a beta-lactam, for example, ampicillin, sulbactam, or ceftriaxone plus macrolide like azithromycin. Option B, respiratory fluoroquinolone like fluoxetine group, this is monotherapy, levofloxacin or moxifloxacin. Now also we manage about if my patient have anaerobic pathogens, then we use metronidazole. Okay, for example, the patient have a lung abscess or periodontal disease. Use around 7 days. Now next, which is supportive care and delivery management. Isotonic IV hydration, correct dehydration cautiously, monitoring fluid balance to avoid exacerbating underlying heart and kidney condition in older patients. Okay, that's important. So even even we use isotonic IV hydration, but very okay, cautiously. Correct, correct dehydration cautiously, because this is an old patient. So make sure to avoid exacerbating underlying heart and kidney conditions. And beside that, we also reorientation, frequent family presence, room illumination during daytime, minimizing nighttime sleep disruptions, and avoiding physical restraints. Pharmacological delivery management, avoid benzodiazepines. Remember that avoid benzodiazepines if agitation poses severe safety risk. Low dose atypical antipsychotics. Use quetiapine or haloperidol. Maybe use short term at minimal doses. Don't use a benzodiazepine in the patient, because it's SpO2 low. You remember that 87%. But if the patient have agitation, then we can use atypical antipsychotics like quetiapine, haloperidol, short term and minimal dose. Now, aspiration prevention protocol, speech language pathologist evaluation, formal bedside swallowing study to assess a gag reflex dysphagia, dietary and positioning modification, thicken liquids, mechanical soft diet, upright positioning 45% for 30 minutes after meals. The goal is a chin tuck maneuver. Okay. Now, that's a very good scenario. Now, have another scenario like this 71 female, 71 years old female, history type 2 diabetes mellitus, and diabetic gastroparesis. They give the new drug 3 weeks ago for persistent nausea and vomiting. Now back to the clinic today with a severe bodily stiffness, resting tremor in her right hand, overwhelming sense of internal restlessness, akathisia, akathisia, causing her to pace around the room. use a new drug, and then causes severe bodily stiffness, resting tremor, right hand, overwhelming sense of internal restlessness, pace around the room. Now, physical examination. Mask-like faces, cogwheel rigidity in both upper extremities and a shuffling gait. So then which of the following mechanism is most likely culprit for these new neurological symptoms? Metoclopramide or ondansetron or erythromycin or benzoprazole. Correct answer, which is metoclopramide. Explained like this: the patient presents with a drug-induced Parkinsonism. We know this is due to drug, but this is what they call this drug-induced Parkinsonism combined with the akathisia. What is the akathisia? Akathisia stands for overwhelming sense of internal restlessness. Overwhelming sense of internal restlessness. They call this akathisia. As an extra pyramidal side effects, they call EPS. Extra pyramidal side effects. Extrapyramidal side effects of metoclopramide. Oh, okay. Culprit, which is a metoclopramide. This drug can cause drug-induced Parkinsonism and EPS, which is extra pyramid side effects. Mechanism of action. Metoclopramide is a prokinetic and anti-enemic, which is against vomiting, acts as a central and peripheral dopamine, which is D2 receptor antagonist. So peripherally is accelerates gastric emptying, however, it readily crosses the blood-brain barrier. Oh, this one because they can cross a BBB. So that's why peripherally it accelerates gastric emptying. But also in the central, then they cross a BBB easily. Now, pathophysiology of side effects. There's a blocking D2 receptors in the basal ganglia, then reduce or substantia nigra with Parkinson, which is dopaminergic, right? Substantia nigra. Repeat trinucleotide with the Huntington disease. Things like that. And tau protein and amyloid thing, which is Alzheimer's. Okay, pathophysiology of side effects blocking D2 receptors in the basal ganglia reduce the dopaminergic neurotransmission, mimicking the dopamine deficiency seen in the idiopathic Parkinson's disease. Mimicking the dopamine deficiency is seen in idiopathic Parkinson's disease. Now, clinical manifestations: Parkinsonian triad, resting tremor, bradykinesia, shuffling gait, mask-like faces, and rigidity, cogwheel rigidity. That's a Parkinson triad. Ouch! Sorry about that. Resting tremor, bradykinesia, shuffling gait, mask-like faces, and rigidity. Resting tremor, bradykinesia. Three things. Number one, resting tremor, the Parkinson resting tremor, which is in resting, but the patient is shaking like that. Number two, which is bradykinesia, which is shuffling gait, mask face, the mask-like faces. And number three, which is rigidity, cogwheel rigidity. So other patient, if he said, oh, my family history have a Parkinson, and double check for me have a Parkinson or not. So remember, have a triad. Number one, which is resting tremor. Patient have a resting tremor or not? No. Number two, bradykinesia, shuffling gait, mask-like faces. Number three, which is rigidity, cogwheel rigidity. Doesn't have a three thing like that. T B TBR, TBR, which is T with tremor, resting tremor. B, which is brady, which is slowly, kinesia, slowly movement, shuffling gait, mask-like faces. And number three R, which is rigidity. Rigidity, which is cogwheel rigidity. The patient doesn't have it. Now, manifestation of the akathisia. Akathisia, which is stand for, which is we know is just a overwhelming sense of internal restlessness. Subjective feeling of motor restlessness causing an inability to sit still, which is vegetative and compulsive pacing. Subjective feeling of motor restlessness causing inability to sit still and compulsion pacing. FDA black box warning. So warns against long-term use more than 12 weeks due to the risk of irreversible tactive dyskinesia, though EPS, which is extrapyramidal side effect, can occur within weeks of initiation in susceptible elderly patients. So that about this drug. So this drug may give for the against vomiting, etc. But then cause about the drug-induced Parkinsonism and akathisia in elderly. Very careful when you use a thing like that. While the options are incorrect, ondansetron, that's a selective 5-HT3 receptor antagonist, does not possess dopamine receptor blocking activity, so does not cause extrapyramidal symptoms or Parkinsonism. Erythromycin is an antibiotic, this is a macrolide, and has a motilin receptor agonist to stimulate the gastric motility. Side effects are primarily gastrointestinal, cramping, diarrhea, or cardiac QT prolongation, not extrapyramidal side effects, not EPS. Pantoprazole, that's a PPI, the proton pump inhibitor, suppresses gastric acid secretion by inhibiting hydrogen ions and potassium ion (ATPase) in parietal cells does not cross into the CNS. So this one bigger molecules than basement membrane, so they cannot cross blood-brain barriers. So to affect dopamine pathway. Okay. So summaries metoclopramide. Metoclopramide is anti-vomiting thing, but then called this the molecule weight which is smaller than able to cross a BBB blood-brain barrier, and then after that they call this drug-induced Parkinsonism, cause EPS syndrome, has the pyramidal side effects. Why are the not correct? Okay, that. Now detailed disease treatment, management, metoclopramide induced Parkinsonism and APS, immediate discontinuation of offending agents. Stop metoclopramide immediately. Most causes of drug-induced Parkinsonism gradually resolve over several weeks, 2 months following drug withdrawal. Alternative gastroparesis and antiemetic management. Short-term motiling agonists, oral erythromycin 40 and 120 mg TID before meal for short courses, 2 4 weeks to prevent tachyphylaxis. Alternative emetics, alternative 5-HT3 receptor antagonist for like odensetron 4 to 8 milligram POBID for nausea control. Why before they say so technically we can use uh, 5-HT3 receptor antagonist odensetron to control nausea better than use other thing, you know, cause metoclopramide cause a lot of side effects like that, especially in older patients. Not good. Dietary adjustments, most frequent meals low in fat and soluble fibers, liquid diets if solid foods are poorly tolerated. Systematic treatment for EPSS driving symptoms. For drug-induced Parkinsonism and acute dystonia. Dietary adjustments, more frequent meal. Okay. Symptomatic treatment for the APS for drug-induced Parkinsonism and acute dystonia. So anticholinergic agents like benztropine 1 to 2 milligram IVPO or diphenhydramine 25-50 milligram IVPO. Note: used with extreme caution in elderly patients due to delirium and urinary retention risk. Now, amantadine, amantadine 100 milligram PO or PID can be considered if anticholinergics are poorly tolerated or symptoms persist. For akathisia restlessness, use a beta blocker. propranolol 10 to 20 milligram PO, BID or TID as first line therapy. Wow, this is first line therapy for restlessness. Benzodiazepines, low dose clozapam or lorazepam short term if beta blockers are contraindicated. If the patient have a COPD, okay.